Okay. You'll be my backup.
Be your backup. That's fine. Hello, everyone. Welcome. Thanks for being here. We are excited for our first coalition meeting of the year. Let me remember to do all the things. So, oh, we're already recording. Yes, look at that. Things are automated. We are already recording. So great. We are excited to have you guys here for the September meeting of the Carolina Community Coalition. And we are kicking off Recovery Month with a great topic and conversation and getting a chance to share some of the data that has been analyzed right here by our very own faculty. So before we go too further, please take a minute to introduce yourself in the chat. Tell us who you are, what organization or department you represent, so we know kind of who's here. We are recording, so we'll have the recording available for other folks to watch later. And we have the chat function. So if you have questions that come up as we're chatting or for our speaker, feel free to throw them in the chat in addition to introducing yourself. I think that's all the housekeeping. My name is Amy Harrigan. I'm with USC, and I'm really excited to introduce Jodi Manz. So Jodi leads operations of the South Carolina Center of Excellence in Addiction. Prior to her role with the center, Jodi was the Chief Behavioral Health Officer for Clear Bell Solutions, providing consulting services on behavioral health policy, payment, and practice. Jodi was previously the Director for Behavioral Health, Aging, and Disability at the National Academy for State Health Policy. Ooh, that's a mouthful. Working with state leaders to design policy solutions to complex healthcare delivery challenges. Jodi also served as Virginia's Assistant Secretary of Health and Human Resources under 2 consecutive governors. And oops, I lost there we go. And as Assistant Secretary, she coordinated and led the state's comprehensive opioid and substance use disorder response, using legislative, regulatory, and budgetary levers to address the overdose crisis across state agencies. She also oversaw outreach and implementation efforts for Virginia's federally facilitated healthcare marketplace as part of the Affordable Care Act implementation. With this background in state government and health policy analysis, she has worked across systems to transform opioid and substance use disorder policy, Medicaid payment approaches, and behavioral health system design. She has a Bachelor of Arts in Religious Studies and a Master of Social Work Administration Planning and Public Policy, both from VCU, which just goes to show you that you can major in all kinds of things, and we love social workers, right? So we're so excited to have Jodi with us today, and I will tell you all that in the short time that she has been working with us in South Carolina, you should be absolutely blown away by the things she has been able to accomplish. And I know she's going to talk a lot about what the Center for Excellence is doing, but it is absolutely amazing in just a short bit of time. So Jodi, thank you, and take it away.
Amy, that was like the kindest introduction ever. Thank you. It's always weird to hear somebody read your bio, but I very much appreciate the shout out for my religious studies undergraduate degree. That was that was probably the most fun that I've had academically in my life, and maybe someday in retirement will again. Let me go ahead. I see some familiar faces. So it's nice to see those of you that I know. Those of you that I don't, it's nice to meet you via the chat. I'm going to pull up my slides here. And as I told Amy, I sometimes struggle with like knowing if what you guys are seeing is what I am seeing. So let's do PowerPoint, share, presentation mode. Presentation mode. Are you seeing it as a presentation? Why
Nope,
does
we're
it do
seeing
that?
the PowerPoint part.
I'm clicking presentation mode. This is what I'm talking about, Amy. Like you would think, you read these bios and you're like, oh, this person has done this thing and it's cool. And then you discover she can't even share a PowerPoint. Okay. Unshare.
2 screens.
You know what will help? Hold on. I might go black for a second, but I'll come back, okay?
Okay.
Am I still here?
You're still here?
Okay. My screen sometimes disappears when I do that. Now I'm gonna unplug this. Am I still here?
I can still hear you. Your visual went away.
I can fix this. I had to unplug all of the things so that you can. No? Well, we might just do this without being able to see me. Eh? Eh? Hey, okay. She's back. I do magic too. Okay. Sorry about the technical difficulties. Let's try this one more time. Gotcha on my laptop. Sorry to all of those of you who are seeing this as a recording. They're like, fast forward. Okay. Okay. Now you can see my slides, right?
Now yes, we're seeing the PowerPoint.
And if I go into presenter mode, now you're seeing it as a presentation, correct?
Yes, you did it.
Success, y'all. And it only took 3 minutes of all of our lives. Okay. Well, let's get to it then. Amy, how long do I have?
About 30 minutes.
Okay, that's cool.
Ish.
I may leave some stuff out. We'll see. We'll see how quickly we get there. So, thank you for the invite. I know I talked with some of y'all just about a year ago as the center was being established. We kind of came online. I came on board last July, and things started to grow pretty quickly. So Amy was kind enough to invite me about a year ago just to introduce what the center is and what the center does. And in the last year, we've done a few things that I want to tell you about. But the thing I'm most excited to talk about right now, and the thing that I think we're going to focus on is these data analyses that the Center of Excellence has put together. You guys are actually the first group of folks to see this, a couple of these slides, and for me to actually talk to you about the cascade of care and what that means and why it matters. So you are a little bit the guinea pigs for this. Hopefully I can speak about it in a way that makes it understandable, but if not, that's what the question and answer portion is for. So let's get to it. You've heard my introduction. Um, just a little bit about the center. If you all have seen me present before, you have seen this slide, but just so you kind of understand what the Center of Excellence is, you will see if you see my email address, I am housed in DeOtis. So I work with DeOtis. I also work with the Department of Public Health, previously DHEC. Those two organizations form kind of the backbone of the administrative function of the Center of Excellence. And then we also work with USC, that really is leading the charge on the data stuff that I'm going to talk about today, with MUSC, who's doing a lot of our training work, and with Clemson, who's helping with some of the technical assistance work that we do. And we kind of organize ourselves into those buckets, but I will say that we all collaborate very, very well across institutional lines. And the goal of what we do here is, I keep hitting that as if it's going to forward it, is found here. Just about a year ago as well, I started working on putting together a strategic plan for the Center of Excellence with the help of an external advisory board. We've got about 22, 23 folks who sit on an external advisory board and kind of guide the work that we do and react to what we were putting together. And taking their input, I put together a couple of components that you can find in our strategic plan, which is on our website if you would like to do some reading. It's really not that bad. It's like 4 pages. So I promise it won't put you to sleep if you're really interested in the strategic plan of the Center of Excellence. But let me make you guys smaller here real quick. The vision for the Center of Excellence is one that I suspect we all share, and that is that all South Carolinians live free from the harms of addiction. And that's all South Carolinians, including people who are in active addiction, people who are at risk of addiction, people who are in treatment for substance use disorder, the families and systems around those individuals, that all South Carolinians live free from the harms of addiction. The mission of the Center of Excellence you saw in that last slide as well, and that's to maximize our opioid and addiction knowledge and resources through community engagement, collaboration, and research. And hopefully you'll see how we do that over these next few slides or the next half an hour or so. As the opioid use disorder, substance use disorder epidemic has evolved, so have the funding sources that are going to states to address that. And every state looks different, right? As Amy mentioned, I worked for the National Academy for State Health Policy for a while, and the thing that I learned in that position, well, hopefully I learned a lot, was that every state kind of has its own unique policy and political landscape. And those are the things that really shape how action is taken on the ground, whether that's through clinical treatment resources, whether that's through just kind of what's available in different parts of a state. Those components look different. And in South Carolina, as the resources around substance use disorder have grown, particularly the opioid abatement funds that have come into the state. One of the things that's necessary is that we're maximizing every single one of those dollars, right? And it's not just the opioid abatement dollars. Those dollars, I think, provide us a good framework because there are some very specific uses of them, and they are new resources to the state. So we do frame around opioid abatement funds, but when I say that our goal is to maximize those opioid and addiction resources, we're really talking about every dollar that comes to the state for that, whether that's through a federal grant, private foundation funding, opioid abatement. We want to make sure that those dollars are being spent in the right way. We want to help folks to do that by taking all of that knowledge that lives in our research institutions, and applying that at a local level. So that's really the mission of the center. And I'll move on from that. We have a few goals here. These are the goals, again, that are outlined in our strategic plan. Creating innovative approaches to addressing SUD in South Carolina through research and evidence really just, I think, underscores that we want to be taking an evidence-based approach to everything that we do. And I suspect that I'm in good company in saying that, but using those evidence-based approaches and the research, much of which is emerging from our own state, to create innovative approaches. And by innovative approaches, I don't necessarily mean like reinventing the fanciest wheel you've ever seen, but the approaches that are going to work in South Carolina in our particular policy and political landscape. Our second goal is to increase knowledge of opioid abatement and other OUD and SUD mitigation strategies among South Carolina's county municipal leaders and their partners, which includes you all. As those abatement dollars specifically have come into the state, there's this set of ways that you can use them, right? These various core strategies, and they're good and they're evidence based and they're part of those settlements. There's a lot of funding that's coming out of those settlements, and those settlements will continue to shift and change over time. But how you use them is you have this kind of specific list of ways that you can do that. And those are things that like you and I are probably pretty familiar with, things like harm reduction, various treatment approaches. They are not necessarily things that county and municipal folks have ever had to think about, nor should they previously. The folks who are running counties and municipalities have been and should be focused on things like utilities and roads and county parks. So they may be less familiar with some of these strategies. And so goal 2 here is a really important one. They're all really important, but to help increase knowledge of what those strategies are so that county municipal folks can be using their share of opioid abatement and other grant dollars in the best ways for their needs. Our third goal is to improve access to evidence-based SUD and OUD treatment across South Carolina. I don't think I need to tell you that we do not have nearly the treatment capacity that we need. I struggle to think of a state that does. There are states that have more, but this has been an ongoing issue, I think, for since the beginning of this conversation, right, is increasing access to treatment capacity or increasing treatment capacity. And we'll talk about a couple of the ways that we do that. Goal 4 is the boring one. It's the one that really is kind of my job as the director of this whole thing, and that's to create sustainable infrastructure, but we won't beat that one. All right. So how do we do that? As I discussed, we have these partnerships. The Center of Excellence itself is a collaboration of the state's 3 research universities, as well as DPH and DEODIS. And all of those institutions are represented in one of these cores. We kind of divide our work into various Center of Excellence in Addiction cores. Today, the one with the bright red star next to it, we're going to talk about the data analytics core. I'll go through the others too, just so you know what they are. But the data analytics core is really led by the folks at USC, specifically my friend and yours, Christina Andrews, who is just an amazing researcher and person and friend. She's doing all of the work to kind of push forward the data reports that we're going to talk about here in a minute. We also have a training core. This one's led by MUSC. The goal there is to really build out the training opportunities for providers, for county municipal leaders, for any partners in decisions about opioid spending. Technical assistance is obviously a big part of what we do. That's kind of Clemson's lane. And what they do is they offer very specific, targeted, free technical assistance to localities and counties, and any entity really that's looking for help with implementing various OUD and SUD initiatives. And then the administrative core, again, that's me, and that's the boring stuff. That's the things like managing budgets, managing reports, putting together PowerPoints, things like that. But big bright red star is for data analytics core because, drum roll, this is what my friends at USC have been working on for just about the last year, doing some statewide data measurement to really understand what the outcomes of our treatment system are. How well is our treatment system functioning? Where are there opportunities? Where are there bright spots? So we are beginning that, or have begun that, I should say, with Medicaid data. The reason we began with Medicaid data is because it's what's accessible, right? Medicaid data is state data. Over time, we will be integrating other payer sources. That includes data around uninsured treatment through our local drug and alcohol centers. I would love to, at some point, be able to fold in commercial insurance data. That one's a little bit tougher. FQHC is kind of other resources for that. But for right now, we have Medicaid data. And the goal is to ultimately produce a picture for policymakers, academic and agency partners of the Center of Excellence, as well as South Carolina localities. And the deliverable here, the thing we're going to talk about, is these local level reports as well as dashboards. The goals of those things are to, this is very much the reductionist list, but to inform targeted investments, right? If we can see how our treatment system is performing, then we can better understand how to spend all of those dollars, how to maximize all of those dollars to get back to our mission. To guide clinical interventions, if we see that certain clinical interventions are leading to, the next best step in our treatment cascade, then we know where we need to be guiding our clinical interventions a little bit differently, improving treatment access, and then finally targeting our own training and technical assistance. Really quickly here, this is just to introduce the idea of the opioid cascade of care. This is where if we were all in a room together, I would ask you to raise your hands if you've heard of the cascade of care, but we're not, so I'll describe it a little bit. Using all of this data, this Medicaid data for now, and like I said, other data resources moving forward, we are taking the framework of the opioid cascade of care, which has 4 specific domains to understand our treatment system. The 4 domains that we're talking about here are diagnosis and identification of opioid use disorder, engagement in treatment, receipt of medication for opioid use disorder, and then retention in treatment. Keep those in the back of your mind. Because this is what the opioid cascade of care is. If you've heard of the cascade of care before, you may have heard of it in the context of HIV. And this was developed a while ago, a few decades ago now that I think about it, and it's frightening to say that out loud. But basically, this is a model that showed a lot of success in HIV, and care for HIV that has really. I think we've all been blown away that in my lifetime, the life expectancy for patients with HIV, the care for people with HIV has improved so dramatically, and part of that is due to this cascade of care model. And what it does is it identifies these key stages of movement and progress through treatment. And in the HIV world, certainly that looks different than for opioid use disorder or any other chronic condition. But this model, because it was so successful with HIV, has been adopted for other chronic conditions, including for opioid use disorder. And it begins with a very simple concept that I think we can all recognize the truth in, and that's that there is a continuum of individual experience. That continuum, and I mean, even this is maybe a little bit misleading, right? There is no straight line, straight arrow of that experience, but the continuum includes all of these various components around, prevention of certain chronic illnesses, including opioid use disorder, identification, and diagnosis, treatment itself, and recovery. And recognizing that continuum kind of helps us to just compartmentalize what that experience looks like for an individual. Applying that specifically, do you like how I used fall colors there? By the way, I did that just for you. Um, Applying that to specific treatment measures was a pretty big undertaking. In 2021, Pew brought together a group of folks, and I was included on this group of individuals. I was part of this panel that put together um, kind of all of our thoughts around treatment metrics related to opioid use disorder, because what we were seeing was that in 2017 there was all this great research that said we should create this opioid use disorder cascade of care. Like we should adopt this HIV cascade of care model for opioid use disorder. And some states were doing that pretty well, but there was no like really specific model for that. And once folks started to develop models for that, we needed to be assigning metrics for each of those stages. And what we identified as a panel was where we needed metrics was around diagnosis, initiation of treatment, retention of treatment, and recovery, which is a list that should sound familiar to you because we talked about it a couple of slides ago. Um, and what we found was that there are very, very many different metrics for all of these things, right? So it was a process of kind of identifying what are the different metrics around opioid use disorder diagnosis. For example, there are what are called HEDIS measures, which if you live in the world of Medicaid billing, that will sound probably unfortunately familiar to you, because billing and coding and HEDIS measures are kind of eye crossing sometimes. But there were a handful of different HEDIS measures for diagnosis. There were also metrics that states were collecting that was just like, well, this comes from our hospital data. When someone comes in on overdose, we'll put a code on for opioid use disorder diagnosis, but then we maybe never see that person again. And for all of these categories, there were multiple metrics that different states were using. So our goal as a panel was to standardize what those metrics should be. I had the honor of being on the group that was looking specifically at recovery metrics. And I will say, I think that was, I mean, obviously, I think this because I'm biased, but I think that was like the hardest one because measuring recovery is so subjective. There's not a HEDIS measure that you can enter into a system somewhere that says this patient says they're in recovery, check the box. So what we ended up doing was identifying these very specific insurance claim based metrics for diagnosis, treatment, and treatment retention, but not for recovery. What we recommended as a panel for recovery was for each state to be able to identify specifically how they wanted to measure that. But most of the metrics come from those insurance claims that you can pretty easily cull from Medicaid and or commercial data if you have access to it. And in some states, you can get access to those things a little bit more easily, and in others you can't. Especially the commercial data is proprietary to most commercial insurers, so that's a little bit more difficult to identify. But we identified the metrics for all of these things. So the way that we decided to do this as a center of excellence, and I should say that our data analytics core, as led by Christina, decided to do this, was to really look specifically at metrics that we could cull and be able to identify those in like kind of in a way that will continue to grow over time and evolve over time. So we're starting, like I said, with Medicaid claims data. And what we're doing is putting together individual county, regional, and state level reports. Each county will have a report that takes those metrics for each of those categories using Medicaid claims data and puts them all in one place. So each county can look at this and say, this is what my report is showing in terms of how my treatment system is doing for people with Medicaid. Over this next year, actually starting just about now, we'll be adding local drug and alcohol center data, which again, because it's part of the public system, is a little bit easier to access. So we'll add that and kind of continue to grow these reports over time. We use these HEDIS measures as well as like HEDIS-like measures that align specifically to the recommendations that came out of that Pew report. I'm happy to send you the link to the Pew report again if you would like any bedtime reading. It actually is pretty interesting, but again, biased. So you all are the first people to lay eyes on this. This is just a screenshot of like the template of what this is going to look like. These county reports are coming out probably within about the next month. Yeah, about that, because it's the beginning of September. So within the next few weeks, these are going to be rolling out. And what these are going to show is kind of the top line number of the amount of people who have died from an opioid overdose in that county in these 7 years from 2015 to 2022. There will be kind of that little blurb there about how treatment is available, but we know it's underutilized, right? Like we don't need to kind of drill into that. But what you see down below here is the application of those cascade of care metrics. So we start with, of the Medicaid enrollees in that county, and this is for individuals age 18 to 54, we don't have youth. I think over time we would like to add that. That's a little bit more tricky. But for right now, it's adult Medicaid enrollees who got a diagnosis, right? Because that is the first step, because the care doesn't start until the diagnosis is there. That's a function of how insurance works. It's a function of how our medical system works. So that first number is, right, how many people were diagnosed. Of those individuals, how many of them were connected to treatment, right? If you got that diagnosis, say in an emergency department, were you connected to treatment? And ideally, were you connected to treatment very, very quickly? And it doesn't have to just be an emergency department. I'm using that as an example. But upon that diagnosis, were you connected to treatment? So it'll show you, you can start to see where the cascade comes in, where these numbers start to go down and down and down. So of those who were then connected to treatment, how many of those individuals received evidence-based medication for their opioid use disorder? That includes buprenorphine, methadone, and naltrexone, all three, injectable naltrexone, I should say, all three of the FDA-approved forms of medication for opioid use disorder. And of those individuals, how many were retained in treatment for a clinically meaningful period of time? And I know you're probably thinking, Jodi, clinically meaningful period of time feels very subjective. And you are correct. That was my first thought too. However, a clinically meaningful period of time is actually generally about 6 months to a year. We know that when we can retain individuals in treatment for about that time, they are more likely to find their way into the end of that continuum that's cut off there. And it's not truly the end, but recovery. So each county is going to have a report that looks like this. all of this information will also be uploaded into a dashboard that will be housed on the Center of Excellence website. I don't have a screenshot of that yet because I am not good enough at Tableau to be the person who's creating it. All I have to do basically is hit upload when I get that information, and that data dashboard will be regularly updated and kept on the Center of Excellence website. That's a resource to you. If you need that information for your locality, for a grant application, or for a report, or because you care about this stuff, that will be available to the public. These county level reports will be available as well. And these reports, like I said, will continuously have new data added to them over time. So the reports will change as we get new data sources. What are these for? We kind of talked about this already, but I think it's important to suss out like why we're doing this. I mean, one of the big reasons is because if you're a locality or you're a person who, sits on your town council, or it has been assigned the task of figuring out how you're supposed to use these abatement dollars, what better tool than something that can show you how well your treatment system is doing at diagnosing, treating, and retaining individuals in treatment. If you can look at that report and understand what your county looks like, that will help you target those dollars. Like maybe that tells you that you need to be thinking more about how to hire a peer, right? Maybe that tells you need to be thinking more about introduction of new and innovative harm reduction services. Maybe it tells you, you're doing pretty well on X, Y, and Z, and you should be investing in something like recovery housing or recovery employment. There's all kinds of things that you could glean from that as a local leader. So we want to create this as a resource for those individuals as part of our mission. This is also important for state policymakers, folks who are developing treatment policy and identifying budget needs. I am not one of those people now, but I used to be one of those people. And having access to this kind of data is priceless when you are figuring out, what should your Medicaid benefit look like? What should we be really, thinking about paying for in our system? If we're going to use public dollars in these systems, how can we maximize those? That's a really important question for state policymakers, and we hope that these reports will help them do that well. And identification of budget needs is always a challenge. I would say that it's the hardest, and also to some degree, my favorite part of state policy is being able to identify where priorities are based on what people pay for. And if we can show the need through these reports to pay for certain components on this continuum, that helps us make better state policy, or helps our policymakers make better state policy. This is also important for insurers who are implementing payment policy. Insurers, both on the Medicaid side, or the public side, I should say, Medicaid and Medicare, and those on the commercial side, need to know what it is that they're paying for and where they should be targeting their resources when they're developing their benefits. And finally, clinicians delivering care. And, I should probably say clinicians and providers delivering care, because it's not just about the clinicians, it's about the teams of individuals who are delivering care and the systems around every individual who's receiving care. But to help folks say, like, this is where we're doing really well, this is where maybe we're not doing as well, so where do we need to like beef up our particular care delivery? And then finally, it helps us too. Like it helps the COE to be able to target our training and technical assistance. If we can see that, X county is just kind of blowing everybody out of the water in terms of their data. Like, what are they doing well? What we'll do as this Center of Excellence is try to identify what they're doing well and scale and spread that as part of our training and technical assistance. It also helps us to identify where things are not going as well. Like, where can we help build out the continuum of care throughout our state, or within those components, or where can we be a resource to policymakers? It really helps us to understand what we're doing too. Quick time check. I'm gonna, no, I'm not gonna stop. We'll hold questions to the end. So that's a lot about data, and I know that some of it feels repetitive and iterative, and that's because it is. But these are really, really important reports that we're really excited about releasing. We're meeting with the county and municipal associations in just a couple of weeks to give them a sneak peek of what these reports are going to look like. We're excited for these to be a resource, and we're excited to see them grow over time. Well, maybe I'll save that for questions. But especially in a state without Medicaid expansion, when we're talking about just using Medicaid data, we're only talking about a very specific population, right? To be eligible for Medicaid in South Carolina, you have to be either a very, very, very low income caretaker parent of a child who is eligible for Medicaid. You have to be a pregnant woman up to 12 months postpartum, or you have to be an individual with a disability. That's a pretty small group of populations, I should say, which is why it's important to us to be able to pull in that uninsured data over time. But right now, that view is going to be limited to those Medicaid populations. Um, did I just see a hand flash up? I'm happy to answer a question if there is one.
Just for a second, but it may have been an accident.
Oh, okay. Okay, well,
Yes.
feel free to interrupt me. Like I don't need to talk this much. Uh, Anywho, yes, right now we're sticking with Medicaid. We're adding the uninsured data. Over time, I mean, if South Carolina were to choose to expand Medicaid, obviously that would increase our data lens. If South Carolina continues to choose not to do that, we have other ways of accessing that data, especially through the local drug and alcohol centers. Again, hopefully eventually through like the FQHCs, and through commercial data, but we'll see where that goes. So I wanted to provide just a few other updates on the Center of Excellence, because we do other stuff too, like I said. Christina and her team, and I got to give a shout out to Banky Olatosi and the folks at the Big Data Center who are doing a lot of the like very specific and very hard, well beyond my scope of intellect work of cleaning the data, processing the data, making sure all the data is correct, and then doing the actual analysis. So the folks at USC have been hard at work for a year on this, and I couldn't be more proud of what they've put together. When we do have those data reports, Amy, I'll send you the link. I'll put it all over like email blasts and stuff too. If you haven't signed up for the Center of Excellence newsletter, I'll put the link to be able to do that in the chat here in a second so that you can be on my listserv and get that information. But we'll be sure to get that information out. But a few other things that are happening at the Center of Excellence. We did a needs assessment in our first year, looking to our county and municipal leaders, as well as their partners, which includes the local drug and alcohol centers, includes the universities, includes recovery organizations, includes prevention organizations, anybody kind of in community on the within the treatment system. We did this needs assessment, and it wasn't too hard. It was like a maybe 10-minute needs assessment, that quantitatively was just kind of us asking, what kind of planning has your locality done around abatement funds or other funds? What kind of planning would you like them to do? What would you like to see implemented? And then we also, so our friends at MUSC kind of conducted that portion of the needs assessment. Our friends at Clemson are currently analyzing all of the data from the qualitative portion of that needs assessment, where they actually went out and did interviews with folks to have specific conversations about what would you like to see in your region. How can we help you with planning and with implementation? So the results of that should be coming out shortly. I'm awaiting those. And when they do come out, again, we will have a report that's posted and it will be on our website, and I'll blast that out to everyone. But I'm excited to see what that shows us because, again, I think there's a wide range of need in South Carolina. There's a wide range of interest. Like some places are really going to want to put a lot of funding towards building out certain components of the continuum. Certain places are not going to be interested in those parts of the continuum. So it'll be helpful for us to see kind of what people have identified as their true needs. We also, starting in just a couple of months, are going to be doing some specific dedicated technical assistance around support for jail-based treatment. Um, Jail-based treatment for opioid use disorder is one of my favorite topics in the world. It's something that I've had the privilege of being involved in, and I've seen how successful it can be. You know, folks who are incarcerated in our local jails are often folks who cycle in and out of those environments, and nobody wants that. Nobody wants to live that life, right? But we also don't always provide systemically the support to those individuals to help them disrupt that, and to empower folks to make different choices. South Carolina is also a state that doesn't have a whole lot of active jail-based treatment right now. There are a lot of reasons for that, and we could probably sit around and turn that Rubik's cube for a long time. But more importantly, is what we're going to do about it, and how we're going to support both jails and their treatment partners, because a lot of times the treatment happens through partnerships, right? It's not like we can just kind of slap treatment into a jail and tell a sheriff thanks and then leave, right? We do that through partnerships with treatment and recovery folks in the community. So I'm really excited to kick off this work. It's not going to start for a couple of weeks because it's all dependent on funding cycles and such. This will not be specifically like us giving money to anyone to do that. I wish we could. We don't have money to do that. It'll be specific dedicated technical assistance to help leadership in localities do this. And then finally, another drum roll. Actually, just before this call, I submitted the information to what I hope will be our site for the 2025 Governor Summit on Opioids and Addiction. Dan, I saw you on this call earlier, so I hope that you will take this as your request to be on my planning committee again next year, because you were so helpful for the 2024 summit. If you were able to attend, I'm so glad. I hope that I had a minute to stop and say hi to you. If not, hopefully I will see you in 2025. We are hoping to do this in fall of 2025. It felt like the springtime was just a little bit hectic last year, but we had such an amazing summit. Again, I am biased, but I thought we had just a wonderful agenda that included some of you, included Amy. And we're so fortunate to have some of the speakers come, and just to have everybody be together in community and be in that environment, I thought was so useful. So I am thrilled to be able to tell you that we're doing it again in 2025. Probably looking at November though, to avoid like those the graduation seasons and the grant application seasons and all of that. So hopefully I will see you there. Again, that is information that I will share very broadly, but we've got about a little over a year to plan that. Finally, oh goodness, okay, I've been talking a lot. Just very quickly, these are the other cores, 2 red stars to talk about training and technical assistance. I just wanted to highlight that we have a couple of other initiatives that are going on. Every other Friday at noon, we do the South Carolina Opioid Response Initiative's ECHO. This is open to anyone who works in this space. So this is really, it started out as being for the county municipal leaders, but also for opioid abatement partners. Anybody in the community who is working to address the substance use disorder and overdose epidemic is invited and encouraged to participate in these. We've had lots of fun on these thus far. It's pretty low effort, like just log on at noon. You can chat with other people who do similar work to you and learn about cool things. You do have to sign up through the specific iEcho platform, but I can provide that information. Technical assistance opportunities. Talked about this a bit at the beginning. We do free consultation and connection with technical assistance experts for strategy and implementation. We do that through Clemson. There's a specific form that you can just fill out. It takes like 10 seconds and you submit that, and then we'll hook you up with the right folks to help you do whatever it is that you want to do. And then we also, in the interest of expanding access to evidence-based treatment, have implemented a clinical warm line. This is for any provider in the state. This is for clinicians and prescribers and social workers and EMTs and anyone who has a question about how to provide substance use disorder or related treatment. So that can be around infectious disease, that can be about connecting folks to community recovery supports, can be about, you know, the really fun stuff like toxicology. But it's also really to help providers think about how to provide treatment, because that can be a really intimidating thing if you're a primary care provider and you have a patient sitting in front of you and you don't know where to begin. You can call this number. It's free, it's confidential, and it's available Monday through Friday. If nobody picks up, they'll call you back very quickly. Lots of opportunities to connect. These are all hyperlinked, Amy. So I don't know if you share the slides, but all of the ways to connect are there. The sign up for our newsletters there, the website where you can see all the fun things that I referenced. You can follow me on LinkedIn. You can follow the center on LinkedIn. That's our provider warm line number. You can request technical assistance through that form. You can join the Echo through that form, and that is my email address. All right. I realize I thought it was like 4:30. I just realized it was like 4:45, and we want to share some time, save some time for questions.
Yeah.
So
Thank
thank
you
you.
so much, Jodi. If we were all in a room, we'd be clapping right now. Really appreciate all the insight and the work that you're doing. And it's so helpful information. And I hope those of you who have heard us talk about the spectrum of services that Sape provides at USC, or as we're talking about the stepped care model in CAPS, it really all links back to this same idea of the cascade of care, of the spectrum of services, of every environment includes prevention, intervention, case identification, treatment, and recovery, right? Like that is the spectrum. That's what we are doing on college campuses. It doesn't look the same as what we're doing in primary care for folks with OUD, but the concepts and the foundation behind it is the same. So it's always fun to me when we see how those things intersect with the work that we do on a college campus. So thank you for that. I want to open the floor for folks who have questions and thoughts and things you would like to know. You can put them in the chat and we can ask them. You can raise your hand and we can try to keep it orderly. But I would first like Kat, while you're thinking of your questions for Jodi, I know Kat James is on the call with us and would love for Kat to introduce themselves and talk a little bit about what we have going on. And this is a part of our Recovery Month celebration on campus. So Kat, I'll let you take it away.
Yeah, thanks. And first, I want to say thank you, Jodi, for presenting on this topic. This was really helpful and interesting. And as Amy said, she kind of stole what I was going to say in my introduction to myself, but it is really helpful to see that what we're doing at Sape on campus mirrors what is happening statewide and what is best practice. So even if our interventions look a little bit different, I was really pleased to see that like we're looking at the same kinds of numbers, we're looking at the same kinds of strategies in evaluating our success. So as Amy mentioned, September is Recovery Month, and this is our first kickoff event at Sape and Gamecock Recovery for that celebration. But I wanted to name a couple additional things that our friends and allies who are on this call can participate in to support Gamecock Recovery in September. The first is next Friday. We are hosting a open house. Oh, yep. Okay, that's fine. I just put some stuff in the chat too, but next Friday we are hosting an open house in a recovery lounge. We'll be serving coffee and donuts. We'd love to have you come by and meet some of our students and see our space again. There have been some improvements from last year. We're really, again, glad to have that space and grateful to USC for providing a space for our students to gather with one another in community. That's next Friday, 3 to 5 p.m. Drop in whenever you're able. Our addiction recovery informed seminar series is kind of like a sister event to this one. We really focus on people's lived experiences and their stories of being in recovery. Amber, who is a peer support specialist at the Courage Center, is going to be sharing her experience of being on MAT and what that has been like for her and how that has played into her role as a community leader as well as a person in recovery. We're really excited about that story. That'll be in the Russell House and virtual. So we are asking folks to please RSVP, especially if you'd like to attend virtually as you did with this one, so we can make sure that we get the links to you and get all of that set up. The link is in the chat. And then the last event, I guess, that I'll call out for today is that we are continuing our Recovery Ally Workshop series. We'll be offering one session for faculty staff on September 23rd and one for students on September 27th. Those are now an hour long with 20-minute pre-work little video that you watch. So that is a shorter commitment than it has been in the past, if that has been a barrier for folks. And we do have some additional dates later in the semester, just calling out those ones because that's our September month, our recovery month events. I also put a link. I know that many of you are subscribed to the Carolina Coalition newsletter, but we do also have a Gamecock Recovery newsletter if you're looking for more ways to get informed about recovery on USC's campus. That's a great way to stay in touch with us.
Thanks, Kat. So I will open up the floor if folks have questions. And I know, Jodi, one of the things that came to my mind, and I saw we have some folks on this call from some of the technical schools and community colleges in the state, who I think often work much closer with their county agencies and kind of their county infrastructure. So I wonder, what do you think, what is the role that some of the schools in the counties can play as we're talking about increasing access to care, or even recognition and diagnosis of OUD for folks?
That's a great question, and I'm going to steal the answer that somebody who works for our state opioid recovery fund board, our abatement board fund, used last week, and that is go to county council meetings. Go there and show what recovery looks like. Show that there is so much value in investing and leveraging the existing resources that we have. And like the community colleges and technical schools are exactly those resources. Like, how can you be a partner to them? Explain to them how you can be a partner to them in how they decide to make those investments.
That's great. And I love that you're looking at the across the spectrum, right? So it's about folks in recovery. It's also about harm reduction services and how we're approaching this issue with all of the opportunities that we have to tackle it.
Yeah, and an example that I use quite frequently is like maybe you have, in your space or in your county or in your office, you've done a really good job with dispensing fentanyl test strips and naloxone. That's fantastic. This could be your opportunity to talk with your county about enhancing your harm reduction services to start including safe syringe exchange, to start talking about how you can do a more comprehensive harm reduction approach and how you can be a resource to them to do that. There's all kinds of, there's all kinds of ways you can focus these dollars. Doesn't have to, I mean, that's one example, but yeah, there's a continuum of opportunity. Pick what you're good at and what you want to advocate for and how you can be a partner, and talk to your county about how you'd like to see them spend those dollars.
Well, and I think, not to brag on us too much, but I think we had a lot of questions when we started the naloxone distribution at USC, and a lot of people were like, do we really need that? Is that really an issue here? And now we're one of the largest distributors in the state, and it's because
That's
we
awesome.
have access to students and mechanisms for getting them those resources in a way that, other agencies may not. So
Yeah. No, brag about that. Always brag about that.
well, try. Good. Any other questions? We will give you a few minutes back in your day. Well, great. Jodi, I can't thank you enough. I'm so excited to see these reports and be able to look at state, county level information and be able to really target where our communities need to make changes and improve. So thank you so much for the work that you're doing and for sharing with us. For those of you who haven't joined one of the Echo calls yet, it is a great opportunity. It's a different topic every time. And so there's been some really interesting conversations and presentations from different communities and agencies and what folks are doing really well in some of the places around the state. Yeah. Well, great. We will see you in a month. The first Thursday in October will be our next coalition meeting, and we will be introducing our new assistant director for coalitions, who will be leading this effort then. So thank you all for joining us. And this recording will be available in just a couple of days. Thank you.